this is the spine. Obviously, it's a very complicated structure. There's a piece of paper under your on your seats. You're going to have to draw it before you can leave. So just remember to do that on the way out. The lifetime prevalence of back pain in high-level athletes, I know Dr. Sullivan said it was about 20, but double that in high-level athletes. I saw about 50%. So it's a, at least a relatively high prevalence that at some point an athlete will get some back pain in their adolescence. It's higher in girls and boys. We don't know why, but that's just what the numbers show. There may be a relation to physical activity, and again, we're not sure if that's directly related, but there seems to be a correlation, but definitely correlated with depression and emotional problems. Again, athletes, depending on the sport, seem to have bigger problems. This is a rhythm gymnast in the top, and obviously a lot of stress on the spine. And even in the bottom picture with wrestling, little kids throwing another kid over your knee, that's a lot of torque across your back for kids. So gymnasts, wrestlers, golfers, rugby players, tennis players, that seem to be the highest prevalence, but again, not nearly the only ones who can get it. There also seem to be high levels of structural abnormalities in high-level athletes. And there was a study that showed in high-level gymnasts that they had thoracocolumnar disc degeneration 75% of those athletes compared to 31% of controlled. And I think that was people with back pain. And then also you'll see Schmorl's nodes too, which are sort of end plate fractures. One of the biggest take-home messages in kids, make sure that you rule out other non-mechanical. Don't write it off as just they have overuse or back strain. There's some bad things that happen in kids. Kids can get some unusual problems. So before you make sure that you do your diligence. They can get disc space infections spontaneously, cancer, inflammatory conditions, or other developmental disorders of the spine. So just be sure before you write everything off that you kind of go through everything. The risk factors for back pain, prior low back pain obviously puts you at a higher risk of back pain. Lower extremity injuries, biomechanics, as we've kind of gone through everything. Incomplete rehabilitation, and then the more you do, obviously, the more you stress your body. So kids these days do a lot more sports than when I was a kid, so that's another factor. Again, the way you train and the equipment you train on also plays a factor. So put this all together when you're assessing your patient. Pain at nighttime only is a big red flag. Infection, neoplasm. So if that's the case, make sure that they get evaluated and probably evaluate with an MRI. This is the kids again. The other side was just that their growing structure, it puts them at a different risk as adults. But as Dr. Sullivan appropriately said, they're not little adults. They have other problems. Spondylolysis and spinal-listhesis. I'm going to go through this quickly because Dr. Simon's going to run through this. But flexion, extension, and rotation sports seem to put you at risk. They get problems at the end of season typically. They rest in the off season and then it recurs when they restart. Can be either generalized or unilateral. It's rare it goes down the leg unless they have some narrowing where the nerves come out. And here we go with the slip. So the spondylolysis is the defect in the pars. Do we have okay. Oh, I guess. So here's the pars that connects kind of the front and the back. The lysis is a stress fracture through there, and listhesis is a slip where the L5 has slid forward over the S1. And what they've done studies that showed, at least in Rossi and Dragoni's study, that of over 4,000 athletes, if you have a lysis, about half of them have listhesis. The good news is it's generally non-progressive, so it is there, it's true. They're going to want to protect it, but it doesn't mean they're always going to have a further slip. And actually, sports participation does not increase the risk of low-grade slips. Obviously, high-grade slips are a different issue, but for low-grade slip, it doesn't end their career. Dr. Sullivan went through the diagnostic tests much better than I ever could. So again, we tend to use MRI for a lot of reasons. Getting just an X-ray to start out with makes sense, but MRI has low radiation and gives us a lot of the good information, although it is more expensive. Treatment. There's no controlled studies for treatment, and my guess is Dr. Simon's going to run through some of this, but rest is the #1 important thing that you can do for someone. If it's an acute injury, you want to wait 3 months. If it's chronic, you want to wait till the problem subsides. And rest means no sports, just their normal activities of daily living. You can do bracing. Scott's going to probably cover a lot of this stuff. Disc herniations. Again, we don't think it happens in kids, but it can happen some. It's unusual. It's about 10%, so it's a really low percentage, but it does happen. If there's a family history of disc herniation, it puts you at a higher risk, though. So it's actually 5 times higher if you have a family history of disc herniation. You'll have one less than 21. My brother had 2 at 18. I had 2 at 18. So, positive correlation. It can be unilateral, bilateral, back or leg pain, weakness, numbness, and tingling. It all depends on where the disc is, how it's compressing the nerves, what kind of pain they're going to have. The key is the size of the disc doesn't always correlate with severity. I've seen people with huge discs with minimal pain. I've seen people with little discs with a huge amount of pain. So location can matter. Also the patient themselves, their perception. Generally the treatment is non-operative. Anti-inflammatory medicines, maybe oral steroids depending on how bad they are. Physical therapy, again, protecting that area. Can't stress enough, and all the therapists in here will say that's probably true, that core strengthening, flexibility is going to keep it from coming back again. I do injections on these people, the epidural injections. It's rare. The youngest I've done is 13, but it's highly unusual, and those are people who are just in horrible pain and not ready for surgery. And then surgery to possibly remove the disc herniation. It's another condition that we see called Scheuermann's kyphosis typically in athletic patients. We don't know exactly what the mechanism it is. It's an unknown mechanism, but it occurs in the thoracic spine, typically between T7 and T10. And it's somewhere between 0.4 and 8% of the population, which obviously is a huge swing. Boys more than girls. And it's actually anterior wedging of at least 5 degrees of 3 or more consecutive vertebrae. They get end plate irregularities, disc space narrowing, and Schmerl's nodes. And the typical patient, and I'll show you a picture in just a minute. The typical patient is adolescent, more than 10 years old, and what they end up with is an increased thoracic kyphosis with a resultant hyperlordosis of the lumbar spine, and their head goes forward, and that's all to keep your force line sort of centered, and that's what the mechanism of that is. It's a rigid kyphosis, so you can't tell them just to stand up straighter. It is what it is. And they typically present with lower mid-back pain with activities and after periods of rest. And here we go with the, gee, I wish I could use the cursor. But you can sort of see these areas here where there's, if I can get that, the vertebrae are slightly wedged forward, which results in the extra kyphosis, and then the lumbar spine has an increased lordosis from that. Treatment is pretty benign in terms of most patients, when they get it, when they reach skeletal maturity, they don't have pain. Structurally, they are what they are, but their symptoms go away. For curves that are less than 50 to 60 degrees, flexibility and posture, again, exercise. You can brace people above 50 to 75, and then incredibly rare surgical need. In general, the take-home message with a lot of the back pain is, again, do your due diligence with making sure you assess the patient, make sure that there's nothing bad going on, and the majority of people will get better just with their exercise and flexibility training. So.